Hi everyone. My topic today is on MERS and SARS, which are specific types of coronaviruses. So coronaviruses are a large family of viruses. I think there's around 7 to 9 of them that produce more respiratory type symptoms such as the common cold. However, there are specific coronaviruses, specifically 3 of them, that have come from animal reservoirs and that are much more they have a much more high morbidity and mortality. They really cause a serious and widespread illness and death. The 2 coronaviruses that I'm going to talk about are SARS and MERS. So if you look at both images, coronaviruses are kind of just named for their crown-like spikes on their surface. The name actually coronavirus is derived from the Latin word corona, which means crown. So this right here is a schematic presentation of the taxonomy of coronavirus. So as you know, you name different viruses. So there's 4 different subgroups of viruses, specifically with coronavirus. The ones that we'll be talking about are the beta coronaviruses, and then the mild coronaviruses, such as this 229E, NL63, OC43, along with HKU1. These are the ones that kind of just cause mild respiratory symptoms like the common cold. And then these SARS CoV-1, SARS CoV-2, and then MERS COVID are the ones that evolved from animals and make humans really sick. Okay, so this is a study that kind of just talks about the origination of these coronaviruses. So the 3 coronaviruses that we're kind of touching on are the SARS and then the MERS. And they originated from bats. SARS originated from bats, ended up going into these cat-like creatures. MERS ended up infecting into camels and then humans, and then SARS CoV-2, which currently we still don't know what the middle person is for infection. While the precise origin of SARS CoV-2 is unknown, it is pretty clear by now that reducing or eliminating direct contact with wild animals is critical to preventing zoonotic transmissions in the future. So this right here is kind of an epidemiological comparison of respiratory viruses. I really like this because it compares just the influenza with SARS and MERS along with the new SARS virus, COVID-19. So SARS coronavirus emerged in November 2002 and caused severe acute respiratory distress syndrome, hence its name SARS. The virus ultimately disappeared in 2004. MERS is a Middle Eastern respiratory syndrome virus that originated in 2012 and continues to cause sporadic outbreaks, although cases have been progressively declining since 2016, and there's like very few cases each year. I think it's less than 10. And then the third novel coronavirus is obviously what we're dealing with right now. WHO declared this a pandemic on March 11th, I believe. And this originated in China, and it's kind of widespread around the world right now. Okay, so after SARS, the original SARS emerged from China in November 2002. It spread to 26 different countries, as you can see with the yellow. More than 8,000 people were infected with this SARS virus, and around 774 people died. This kind of drew a collective group of researchers throughout the world because of this widespread transmission. And then this virus disappeared in 2004, and it's most likely due to contact tracing along with case isolation measures. And then afterwards, there weren't any coronaviruses besides the mild ones that just caused, cold-like symptoms. In 2012, September 2012, in Saudi Arabia, MERS started originating. It was identified as a second coronavirus that was transmitted in terms of zoonotic transmission. And then researchers started initiating studies to study MERS. So just as like a review, SARS was first reported in 2002. It was believed to have been spread from bats, and then it infected cats, and then it transmitted to humans. There's no new cases since 2004. The MERS virus was first reported in 2012 in Saudi Arabia. It was often from touching infected camels, and there's limited transmission between humans through close contact. So it's usually that humans will get it through the camels or consuming their milk or meat. Most of the cases are linked to the Middle East and the Arabian Peninsula, and cases have been steadily declining since 2016. So this right here kind of just shows how a virus infects a human. This is showing the SARS coronavirus 2, although the mechanism of action for SARS COVID-1 and then MERS COVID-1 is pretty much the same, just different receptor bindings. So coronaviruses primarily infect like human lung cells. So they infect type 2 pneumocyte cells that contain this angiotensin converting enzyme receptor. As you guys recall from physiology, this receptor is in the renin angiotensin aldosterone system. And that's like what we take many blood pressure medications for in the US. As the first step, there's a spike protein on the SARS virus that attaches and infects the receptor. The virus leaves its coating, it kind of disintegrates, it uncoats, it goes through translation along with replication and translation. Oh, sorry. Oh, where did it go? Well, okay, there. And then it goes through translation, and then it goes through the Golgi body, and then it goes into a vesicle, and then it's exocytosed into the body with like multiple hundreds and thousands of copies made. So this is how it infects the human body. The viral RNA right here, it ultimately makes hundreds of thousands of membranes, envelopes, and more spike proteins to be able to synthesize more viruses in the vesicles. The cells then release these viruses, which ultimately activate kind of the inflammatory response in our human body. So this is a study that compared SARS, the current coronavirus, along with the previous SARS, and then MERS. The previous one specifically targeted angiotensin converting enzyme, and then the MERS targeted this, it's a serine protease that is kind of all over the body in multiple immune cells, the central nervous system, your lungs, your skin, your placenta, and then angiotensin, like I said before, it's mostly in the lungs, and it causes a multiple dysfunction in terms of like blood pressure, electrolyte imbalance, such as sodium water retention, inflammation, and vascular permeability. So the current COVID-19 is actually much more similar to ACE2 in terms of its mechanism of action rather than the DPP4. And then ACE2 will ultimately result in things like acute lung injury, adverse myocardial remodeling, vasoconstriction, along with like impacting the vascular permeability. So this is where current virus and antiviral therapies are kind of targeting, is this like ACE2. It's also why ibuprofen, they say, doesn't work as well as Tylenol, because ibuprofen works towards ACE2 versus Tylenol doesn't interact with this receptor at all. So this is a study that kind of just talked about COVID-19, but it's very applicable to SARS and MERS as well, because both SARS and MERS, in terms of host factors, they both, well, SARS CoV-1 infects human angiotensin converting enzyme 2, and then both of them are much more common and prevalent in those who are elderly and those with underlying diseases such as hypertension, COPD, diabetes, heart disease. A lot of the mechanism of action is very similar with the current COVID-19 and the previous SARS and MERS, in terms of just creating coagulation, dysfunction, septic shock, respiratory distress, along with this like cytokine storm and hypoxia due to the inflammatory responses. This right here, as you know, it's the spike protein, the S protein. That is predominantly what binds to our angiotensin converting enzyme receptor. So there are a lot of studies that are targeting the spike protein as well to prevent the binding of the virus. As you also know, in terms of just the cytokine release and the inflammatory response, when a virus binds, you have your antigen presenting cells that present the antigen to the CD4, the T helper cell, and then that activates the foreign antigen it releases like interleukin to stimulate the CD8 T helper cells that will target any cell in terms of, like creating B cells and things like that. So that kind of just targets inflammation and kind of just produces antigen-specific antibodies. So this is just like a review again. MERS, the most common symptoms are fevers, chills, myalgias, and cough. 1/3 of patients will also have GI symptoms. Because MERS is still, you can have like probably a couple of cases a year, you would suspect this in a patient who was traveling to or resided in an area where MERS was recently reported or where transmission could have occurred, aka Saudi Arabia. Testing is usually done at state health departments. A lot of the laboratory values with MERS, the patient can have an elevated LDH along with AST levels. They can also have low platelets and lymphocytes. Patients can also present with like things like acute kidney injury and DIC. So SARS CoV-1, there's no new cases since 2004. It's transmitted person to person. Although there's no new cases, SARS should not be considered eliminated because the causative virus has an animal reservoir, which it could conceivably reemerge, aka which is what happened with COVID-19 when it reemerged in December 2019 in China. Diagnosis of SARS is made clinically and treatment is supportive. Once again, the coordination of prompt and rigid infection control practices helped control the 2002 outbreak. The incubation period for SARS-CoV-1 was approximately 2 to 10 days, but currently COVID-19 is 2 to 14 days. So this was a study that compared all three zoonotic transmissions, COVID-19, SARS-CoV-1, and then MERS. So it kind of just compared their symptomology and things like that. A lot of the common symptoms are fever, cough, shortness of breath, sore throat, dizziness, nausea, vomiting. Patients will also have chest x-rays or radiology findings with like bilateral or unilateral infiltrates, and things like that. Obviously, they have a mortality rate, especially in the people that are admitted to the ICU, the people who do develop acute respiratory distress syndrome, and the people with acute kidney injury. So this was probably my most favorite study that I found throughout all of my research. This was actually published 3 days ago in the Nature journal. I've included the link, so you guys should definitely check it out. It kind of goes through the extrapulmonary manifestations from COVID-19, and this is also very similar to SARS CoV-1. However, SARS CoV-1 back in 2002 only produced predominantly respiratory symptoms, and now SARS CoV-2 is producing a lot of hypercoagulopathy and extrapulmonary manifestations such as Guillain-Barré, encephalopathy, acute kidney injury, along with patients will probably present with like a PE or a DVT. Patients may end up in cardiomyopathy, MI, myocarditis. There have been a few cases of myocarditis as well, along with like things like DKA. And then they can also have vesicles and rashes as well. So it's kind of just important to keep a broad differential when you're working up patients because COVID-19 is associated with kind of just deleterious effects on many organ systems. So this is my case study. The chief complaint is, I passed out after peeing this morning at 5 a.m. HPI. Mr. Smith is a 70-year-old male with a history of hypertension and hyperlipidemia who presents with a syncopal episode this morning. He got up at 5 a.m. to urinate. He finished urinating and took a few steps and then passed out. He denies any preceding symptoms, no nausea, headache, chest pain, or shortness of breath. He is unsure for how long he was out and says he did not hit his head. He was able to get up afterwards and ambulate with his walker. He denies any fevers, chills, or dysuria. He has been having shortness of breath for quite some time with some mild edema in both legs. He talked to Dr. Macer about this, but they felt no changes were needed to his medication regimen. Otherwise, he is a very spry and independent man. The location of the incident was at home, and the exacerbating factor was changing position. He did not have any therapy today, and risk factors consist of hypertension and a previous history of dysrhythmia. He also complains of a dry cough times 2 days. He states he went to church 2 weeks ago and was around multiple people who were coughing. He states he also has fevers and chills, but denies taking a temperature. He denies any recent travel. So subjective findings. He's on multiple medications such as hydrochlorothiazide, metoprolol, finasteride, spironolactone. He doesn't have any allergies, no smoking, drinking, or recreational drug use. He is widowed, retired, and lives alone. He has a nurse that visits him daily. And in terms of family history, there's heart disease and stroke. So a review of systems is positive for dry cough, shortness of breath, and syncope. He doesn't have a headache, no numbness or tingling, no photophobia, no nausea or vomiting, no palpitations or chest pain, no weakness or changes in speech, no vertigo or anything like that. In terms of objective findings, he's a slightly tachycardic, slightly hypertensive, his temp is fine, his O2 saturation is fine, and then his full physical exam is benign and unremarkable besides the tachycardia. So these are the initial lab work. These are the abnormals. So he does have a high BUN and creatinine. He did have an elevated troponin, but his second troponin was 0.14, so it's kind of trending down. And then he had an elevated BNP. We also have a pending SARS coronavirus test that hasn't resulted yet. So in terms of differentials, I'm thinking maybe it's a PE. The guy is, he's an elderly male with a syncopal episode who presents with shortness of breath. He's tachycardic. Maybe it's an MI or an arrhythmia because he has a syncopal episode. Maybe he did hit his head, but he doesn't recall hitting his head. Maybe it is coronavirus because he did complain of dry cough, fevers, and chills, along with sick contacts 2 weeks ago. Or maybe it's just a community-acquired pneumonia. And then I'm thinking in terms of diagnoses of exclusion, it's probably a micturition syncope because he syncopized after urinating in the morning, or it might be just a dehydration / orthostatic hypotension. So here's his EKG. It shows sinus tach. It shows a prolonged QT interval along with a delayed R wave progression. There's no hypertrophy. It's a left axis deviation. There's significant anterolateral T wave inversions. So it's a little concerning EKG. Maybe there is something going on. He's definitely tachycardic. This is his chest x-ray. It shows bilateral peripheral pulmonary opacities. There's a prominent right cardiac border as well. So this is a little concerning as well. So we did a point of care ultrasound because the EKG and chest x-ray were kind of concerning for a PE. The point of care ultrasound showed a right ventricular dilation, so that's a little concerning. And then we skipped the D-dimer because he's a 70-year-old and he is a high-risk patient, so we went straight to a CT angiogram of his chest. This showed saddle PEs in both branches of the pulmonary arteries. We also did a non-contrast head CT just to be sure because he is a 70-year-old who syncopized, and you may or may not know if he did have an intracranial hemorrhage or not, and you need to rule that out. Despite his normal neuro exam, it is still important in an elderly male to do a non-contrast head CT. So it was no acute intracranial abnormality. So assessment and plan. Currently, my working diagnosis is that he's got a PE, he's got saddle PE. He's still pending on coronavirus testing, but I am thinking that it possibly is COVID because COVID presents with coagulopathy. So the plan is to admit him to the ICU. I don't think he has COVID pneumonia at this time, and we're going to treat the PE with IV heparin. We're also going to provide supportive care such as supplemental oxygen, IV fluids if he becomes hypotensive, along with anything for nausea or vomiting. We're going to admit him for continued anticoagulation and observation. He's pretty stable at the time right now. So management in terms of COVID patients. There's currently no approved antiviral treatment. There's multiple therapies under investigation and multiple clinical trials going on. In terms of a mild or moderate disease, you usually discharge them home. You ask them to isolate. You educate them in terms of symptoms and when to return to the emergency department. You treat them with things like I've seen providers give Z-Paks or a short course of dexamethasone or prednisone, like 40 milligrams for a couple of days, along with Tylenol, Zofran, things to kind of just control the symptoms because there's no antiviral treatment. In terms of a severe disease, these patients will usually be admitted. And then they'll probably need supplemental O2. And then if they end up in ARDS, then they'll probably need to be intubated and placed on a ventilator. So this is the patient in day 3 in the ICU. So this is 5 days of his symptoms of a cough and approximately 2 weeks, 3 weeks after his exposure to sick contacts. So it shows ground glass opacities in the right upper lobe and the left lower lobe. This is his chest CT that shows bilateral subpleural ground glass opacities as well. So some investigational therapies, which I'm sure you guys know for coronavirus right now, are remdesivir. That's pretty promising. I think it's a 64% success rate, and there's a lot of clinical trials going on, even at Emory main campus. Dexamethasone is promising. They usually recommend avoiding hydroxychloroquinolone. You can give a Z-Pak outpatient. This lopanavir and ritonavir was a study that was done in China, but in terms of like the US, the NIH recommends against it. And there's still insufficient data for interleukin 6. So these are some investigational therapies going on. The most promising, I think, is remdesivir. So yeah. So question number 1, what are the primary symptoms of coronavirus? Fevers, chills, shortness of breath, cough, fatigue, myalgias, or runny nose. It's a select all that apply question. So the answer is all of them. So one of the things to watch out with COVID patients or potentially a reemergence of SARS coronavirus 1 or MERS if the patient has a positive travel history to Saudi Arabia, is to watch out for other symptoms like nausea, vomiting, abdominal pain, a rash, feeling kind of just lower extremity swelling, a DVT. These are kind of just like different symptoms that can also present. Maybe the patient has an acute kidney injury or DIC or things like that. Question number 2, what in a patient's social history would make you concerned for any type of coronavirus? The 3 zoonotic ones. So the answer is things that should lead you towards the differential of COVID or coronavirus is a recent travel history, especially if it's to Saudi Arabia or China. But now it can be anywhere with SARS-CoV-2. And then any exposure to a patient with a suspected or confirmed case, that should definitely point you towards COVID. Alrighty, so these are some articles to read. I found these articles very interesting, so if you have free time, I definitely would read them. Like, it talks about COVID-19 and multiple myeloma. It talks about how remdesivir is being used to prevent MERS in monkeys, so that's a promising treatment. It's a great articles right here. These are my references. And then this was an article that I found that kind of just touched on the different drugs. I found this picture to be very enticing because it kind of talks about the different treatments and where they work in terms of like these pathways, like disulfiram, tocilizumab, which this one works really well in multiple myeloma patients, remdesivir, and then there's also, hydrochloroquinolone, and then multiple other ones as well. So I found this pretty interesting. So if you guys want to take a look at this article. Alrighty, thank you guys.